My name is David Sears. I am the Director of Healthcare Quality for AMIND. I'm also an Assistant Clinical Professor of Medicine at the University of California, San Francisco. I have a specialty in internal medicine and a subspecialty in infectious diseases. I would like to draw everybody's attention to the date of this talk, which is April 29th, 2020. As the evidence base rapidly expands for COVID-19, many of the recommendations and much of the data cited in this talk will become dated, and we will try to update our guidelines and recommendations going forward. We have three main objectives for the talk today. Number one is to learn how to identify patients suspected of having COVID-19 and determine the appropriate level of care and follow-up. Number two is to identify indications for COVID-19 testing and utilize proper specimen collection. And number three is to order appropriate supportive care for patients with COVID-19 and describe the current accepted management and potential treatments for those with moderate or severe disease. So I have the good fortune of serving on our inpatient COVID clinical care unit at the end of March of this year, and we will start by talking about one of the cases during my time on service. In many ways, this is a very typical presentation of severe COVID. The patient was a 69-year-old man who had metastatic prostate cancer, hypertension, and GERD. On his first day of symptoms, he developed a non-productive cough. The next day, he had a subjective fever. And on the third day, he went to urgent care. His vitals were notable for an elevated temperature of 100.9, elevated heart rate of 103, respiratory rate at 20, and an O2 saturation that was normal. His exam was notable for clear lungs, and he was in no respiratory distress. Nasopharyngeal swab was sent for COVID-19, which later returned positive, and we were still in influenza season, so he was also tested for influenza, which was negative. This was his chest x-ray at the time. So day 3 of symptoms, he had a completely normal chest x-ray. Patient was sent home, and on day 6, he returned to the emergency room with increasing dyspnea, and his cough, which had initially been dry, was now wet. He was afebrile at the time he arrived in the emergency room, heart rate of 91, blood pressure elevated at 165/80, respiratory rate elevated at 92, and with an O2 saturation that was now 96% on room air. He had clear lungs, was mildly tachypnic on exam. The decision at this time was made to admit the patient, and he was admitted to the floor. Blood cultures were also drawn, which were negative, and his admission labs were notable for a normal white blood cell count, but a low absolute lymphocyte count of 890. And this was his chest x-ray at the time of admission. So day 6, still read as a normal chest x-ray. The following day, he had a rise in his O2 requirement, was now on 4 liters nasal cannula, and began to have some faint bilateral patchy opacities. These are mainly in the upper lobes on his day 7 chest x-ray. So here we are at day 7. Also on this day, he was noted to have a rise in his creatinine from 1.3 to 2. And the decision at the time, again this is in March, was made to start him on a 5-day course of hydroxychloroquine. On day 9, within a 4-hour period, patient's clinical condition changed rapidly. He started to develop an increasing O2 requirement, went from 4 liters nasal cannula to a non-rebreather to high-flow nasal cannula at 35 liters. He had increased work of breathing and respiratory distress, and he was intubated for hypoxemic and hypercarbic respiratory failure. His chest x-ray at day 9, the time of intubation, began to show more diffuse bilateral patchy opacities. He was on 60% FiO2 at this time. A few days later, his O2 requirement had risen to 90% FiO2. He was in 3-pressor shock. He was paralyzed and started on an inhaled nitric oxide to improve his ventilation and oxygenation. And at this point, he had started to develop substantial bilateral infiltrates consistent with ARDS. So like I said, this is a very typical case, at least for severe COVID disease, and a lot of features of this case, including the patient's late but rapid clinical decompensation, are actually very typical of COVID-19. So in this talk, we will go through, number 1, the epidemiology of COVID-19, 2, transmission, 3, risk factors for COVID-19 acquisition and severe disease, 4, clinical manifestations of COVID-19, 5, COVID-19 suspect identification and testing, and 6, treatment. So number 1, detailed recommendations on operational planning. 2, medical ethics. 3, detailed infection control strategies. We will talk a little bit about infection control throughout this talk, but we will not go into depth on some important topics, including housing and depopulation approaches, isolation of cases and suspects, quarantining of exposed patients, cohorting, and the use and reuse of personal protective equipment. We'd like to note that the CDC addresses many of these topics on its page outlining COVID-19 guidance for correctional and detention facilities. So, let's begin with epidemiology. The epidemiology is changing rapidly, but we now know that there is community transmission widespread throughout the United States, and you can get up-to-date information on both COVID epidemiology in the United States and COVID epidemiology worldwide through a number of sources. Probably the most reliable source is actually your local county Department of Public Health, but there are a number of websites that aggregate this information and make it easy to sort and display, including the references that I put here from both the New York Times and Johns Hopkins University. Also, many correctional facilities are both tracking and reporting the epidemiology of COVID-19 within corrections. This is an example slide from the California Department of Corrections and Rehabilitation. This is publicly available. They have listed by institution the number of patients who are tested and those who have been confirmed to be positive, as well as some outcome information on deaths and number of patients with resolved infections. Determining the local epidemiology also is incredibly important for figuring out what your pretest probability is for COVID, and much of that will really be influenced by how much community transmission you are seeing both within the institution as well as in the community surrounding the institution. So let's talk now about transmission, how COVID-19 is spread. So the transmission is really person to person. It enters the body, the virus enters the body through respiratory mucous membranes, the mouth and the nose being the primary modes of transmission, and there is some evidence that COVID-19 may be able to enter through the eyes and cause both conjunctivitis as well as all of the other usual manifestations we see. Transmission can happen through 2 primary methods. So one is direct contact with respiratory droplets. This is usually through inhaling through the mouth or nose respiratory droplets. Generally speaking, a patient has to be within 6 feet of a source patient to have a high risk of acquisition. At the same time, there is growing evidence that transmission may occur beyond 6 feet. There is also indirect transmission of COVID-19, and that occurs through contact with fomites. These are inanimate objects covered in infectious material, and they can enter into the host patient's mucous membranes through fingers, most commonly, as well as other materials such as sharing of utensils. There's been a lot of interest in figuring out how long COVID-19 will be viable on these inanimate objects. We have one research letter that addresses this, and I'm sure more will be forthcoming. And this research letter found that COVID-19 could survive up to 72 hours on plastic and stainless steel, up to 24 hours on cardboard, up to 4 hours on copper. We will need additional information both to verify this and also test a number of other surfaces as well. In addition to the transmission methods previously discussed, there are certain aerosol generating procedures that can heighten the risk of transmission by aerosolizing smaller respiratory secretions well beyond 6 feet. Most of these happen in a medical setting. They include mechanical ventilation, but also non-invasive ventilation. So this includes CPAP. So your stable patients on CPAP at night are at risk of aerosolizing COVID-19 if they are infected. It also includes high-flow nasal cannula. So this is a separate delivery mechanism compared to regular nasal cannula. High flow generally delivers more than 10 liters per minute. Tracheostomy patients also are able to aerosolize COVID-19. The administration of nebulized medications, but not routine inhalers, is considered an aerosol generating procedure. Open suction and intubation as well may aerosolize COVID-19. So what does this mean for PPE and isolation? When caring for most COVID-19 patients and suspects, we can use gown, gloves, face shield or goggles, and a surgical mask. The isolation does not need to be in negative pressure rooms, but should be kept well beyond 6 feet from others. One exception for these routine patients who are not undergoing AGPs is that we would use an N95 as opposed to a surgical mask during respiratory swab collection. At that time, as a healthcare worker, you are very close to the respiratory tract and you may provoke sneezing or coughing during that procedure, so an N95 is recommended. Now, if there is an aerosol generating procedure in a COVID-19 patient or suspect, we would use the same PPE, except in that scenario we would always use an N95 respirator as opposed to a surgical mask, and ideally that patient would be isolated in a negative pressure room, again ideally with solid walls and doors, and the physical distance from other COVID-19 negative patients would be much greater. Now we will discuss how COVID-19 is spread. First, symptomatic transmission is probably still driving the majority of the epidemic. We know that the highest levels of virus and respiratory secretions occur right around the time of symptom onset and then slowly begin declining following each day from the start of symptoms. During the symptomatic period, of course, individuals are much more likely to cough and to sneeze, and therefore more likely to spread infectious respiratory secretions more widely. Unfortunately, from an infection control and epidemiologic standpoint, there is definitely documented asymptomatic transmission. We don't know what proportion of new cases are coming from asymptomatic transmission, but again, this has been documented many times, and it certainly is part of what is driving the epidemic. Finally, there's increasing evidence for the role of what we are calling pre-symptomatic transmission in generating new cases of COVID-19. Pre-symptomatic transmission is thought to occur primarily within the 48 hours prior to symptom onset. We are aware now that during these 48 hours, patients start to develop very high levels of the virus and respiratory secretions. And even though they may not be coughing or sneezing because they are pre-symptomatic, these high levels of virus can spread to other individuals and can cause new cases. There have been a few studies looking at this, and estimates range between 6 and 44% of new cases may be happening from pre-symptomatic transmission. So what does this mean for PPE and isolation? First off, universal masking of patients and staff is highly beneficial. Many of the new cases of COVID-19 in communities, and we also suspect within correctional facilities, are coming from individuals who will never have symptoms or who do not currently have symptoms but may be about to develop symptoms. Therefore, masking every single individual within a congregate setting such as a correctional facility will be vital to controlling the epidemic. Additionally, widespread testing of asymptomatic patients, particularly close contacts, but really every single asymptomatic patient, is a vital infection control strategy. This should really be done within all congregate settings, such as what is being done now at nursing homes, and what really should be done within all correctional facilities, particularly correctional facilities that have high levels of cases or rising numbers of cases as well. Testing every single person within that correctional facility will give us a very important marker of how many people are infected and who should be put into medical isolation as well. We cannot rely on just testing symptomatic patients to have a picture of the spread of COVID within correctional facilities or to have an idea of how we should appropriately isolate or quarantine patients. We should really be moving toward this goal as these testing bottlenecks are relieved of testing every single patient. So now let's review some of the key takeaway points from the epidemiology and transmission sections of this talk. First key point is that in correctional settings, all patients are at risk for COVID-19 acquisition, even in institutions without recognized COVID-19 cases, or even in institutions which are situated in communities that don't have widespread COVID-19 transmission. There's enough transmission throughout the United States that in the right clinical scenario, patients should be considered suspects for COVID-19, irrespective of surrounding transmission. Additionally, transmission occurs when respiratory droplets come into contact with the mouth or nose either directly, that's through inhalation, and usually is within 6 feet, although I don't think we can confidently say that people are completely protected beyond 6 feet. And that transmission can also occur indirectly, usually through fingers, utensils, etc., when those objects or parts of the body come into contact with infectious material and then enter the mouth or nose. Third, airborne transmission well beyond 6 feet can occur with aerosol generating procedures. And finally, the last take-home point is that transmission during the 48 hours before symptom onset is an important factor in disease spread and may also occur from asymptomatic patients. Finally, I'd like to remind you that AMIND at UCSF, that's our organization, is a health-focused correctional culture change program led by experts in medicine, public health, and correctional health and policy. We work with U.S. corrections departments to promote the health and well-being of people who live and work in U.S. jails and prisons. I'd like to thank you so much for your interest in this presentation, and really thank you for your service, and hope that you stay safe in caring for these patients. We understand there's a lot of information. If you have additional questions, or if there's a topic or question you'd like us to address in the future video, please email our program manager, Kevin Reeder. And you can visit us at amind.us. Thank you.